I'm Dr. Roy Chemaly. I'm an infectious disease specialist at University of Texas MD Anderson Cancer Center in Houston, Texas. Now I'm going to address frequently asked questions in immunocompromised patient population. How does the T-spot TB test perform in patients with HIV and latent or active TB? When we looked, and this study actually looked at 608 HIV-infected patients who were tested with IGRA test or IGRA assays. And if you look at this graph, when patients with HIV tested negative on the T-spot TB test, which was in almost 88% of the cohort, no patient developed TB disease down the road at a mean follow-up of 2.57 years. When we looked at the indeterminate result, or what we call invalid for the T-spot TB assay, only 1.6% were invalid. And these 10 patients who had invalid result, no patient had active TB down the road during the period of follow-up. In 64 patients, or 10.5% of the cohort, the T-spot TB test was positive, and out of the 64, one patient developed TB disease down the road. So as you can see, the sensitivity and the specificity of the T-spot TB test in HIV-infected patients were pretty good. And on the right side of the screen, you see the negative predictive value was 100%, meaning if someone has negative test on the T-spot TB assay and patient with HIV, no one will develop TB down the road. And the low indeterminate or invalid test was only 1.6%. This is the meta-analysis of an IGRA test sensitivity in HIV patient with culture-confirmed TB. Here we're talking about patients with acute TB and HIV. And when you look at the different study included in this meta-analysis, comparing ELISA, which was the quantiferon, versus the ELISpot, which was the T-spot TB assay, and you see that this sensitivity was much higher on the ELISpot assay across the study, except in the last study from Markova et al., where it was only 62% sensitivity compared to 92% sensitivity. But here, keep in mind that 4 out of the 13 patients listed here had invalid tests, and they were included in this calculation. If you exclude the invalid test from this study, the sensitivity of the T-spot TB test goes up to 88%. It's comparable to the ELISA assay. Now, different professional societies like ATS, IDSA, as well as the CDCs came out with guidelines for HIV in 2017 when it comes to MTB or mycobacterial tuberculosis, as well as testing for latent or confirmed TB. So what they came out with, that individuals who have a prior latent infection with MTB, not treated, and then acquired HIV infection later on, they may develop TB disease at a rate of 5 to 10% per year. And this is in the absence of good treatment for HIV or effective HIV treatment. Now, what we also know, and that's what they put it in the guidelines, that false negative reaction from the TST can occur more frequently in patients or in persons with clinical condition associated with immunosuppression. We know that, including HIV as well. Now, treatment of latent tuberculosis infection has been demonstrated to reduce the incidence of TB disease, including persons with HIV infection. So treatment as preemptive therapy before they develop acute infection, it is pretty effective. And we know that individuals at high risk of progression of TB include those with HIV infections. But when they looked at the sensitivity of IGRA tests, either quantiferon plus, gold plus, or T-spot TB testing, to detect LTBI in patients with HIV, it could be around 65 to 100%, while the sensitivity or the skin test for TB is only 43%. How do different assays to diagnose latent TB perform in patients prior to transplantation? Another immunosuppressed group of patients. And this is another meta-analysis looking at different IGRA testing, as well as TST in transplant candidates. Total of 16 studies included in this meta-analysis, and they concluded that the IGRAs have greater sensitivity and specificity than the TST for diagnosing latent TB in people tested prior to transplantation. But this report did not analyze the influence of immunosuppression on this result, as they cite a lack of information in the articles included in the meta-analysis. But when you look at the tables comparing sensitivity, specificity, positive predictive value, and negative predictive value for the different assay available, you see the lower sensitivities was for the TST, 46%, and actually, when you compare QFT and T-spot TB test, almost the same sensitivity, and also the specificity is above 86% for the three assays. But for the positive predictive value, lowest for TST, and the highest for QFTs. But when you look at the negative predictive value, the highest percentage was for the ELISpot T assay. And I showed data earlier about the highest negative predictive value of the T-spot TB assay when you compare to quantiferon or even TST. How do different assays to diagnose latent TB perform in patients with cancer? And this is data actually from our cancer center. We tried to compare different type of interferon gamma release assay to diagnose latent and active TB infection in patients with cancer. And this data we presented at one of the national meeting of the American Society of Transplant Cellular Therapy in 2019. It was a data, we analyzed the data consecutively because early on at our center, we were using quantiferon assay to diagnose latent TB before cancer therapy or before transplantation. But when we saw the result of, and I'm going to go over the result of the quantiferon, we decided to switch to the ELISpot assay platform, which was the T-spot assay that we used it later. We started using it later on. But looking at the result, as you see here, out of the 591 tests that we did on cancer patients, we had 65% on the quantiferon assay who tested negative, but even when they tested negative and they become immunosuppressed later on, 2 patients developed active TB. Now, 3% had positive assay, but no one developed TB down the road. And what is more concerning, actually, is the higher percentage of indeterminate tests in immunocompromised patients, 31%. No one developed active TB, but the 31% were very concerned because we didn't know what to do with these patients. Do they have latent TB? Do we need to put them on prophylactic therapy or not? We didn't know. And even if you repeated the quantiferon test, we could have the same indeterminate result or even negative or positive, but we don't know which one to believe. Now, when we switch to the T-spot TB assays, we looked at 1,009 tests, and what we found actually, 82% were negative. And out of this 824 who tested negative, 1 patient developed TB down the road. But when we looked more into detail on this patient, we found out that this patient were already on 4 drugs because of active TB. And 2 weeks later, after the patient was diagnosed, we did the ELISpot. Someone did the ELISpot assay for curiosity, and it was negative. But patient had already culture confirmed, and they were treated. And that's why probably they had negative ELISpot assay. 4% of the patient tested positive on the T-spot TB assay, and 1 patient down the road developed active TB. We had 2% borderline tests, which were 15 patients, and no one developed TB tests. But the invalid test, which is different than the indeterminate test, 10% had invalid tests, which telling me that this patient did not have enough PBMCs or peripheral blood molecular cells in order to run the test. That's why it's invalid. And out of the 104, 1 patient developed active tuberculosis. So our conclusion were that approximately 1/3 of the QFT tests in cancer patients had indeterminate result, as we showed you here, compared to approximately 13% of the T-spot TB, which had invalid or borderline result. But we know that the low absolute lymphocyte count seemed to be an important factor in inconclusive QFT testing. And the mechanistic explanation is that T-spot TB test requires initial isolations of peripheral blood mononuclear cells. QFTs use whole blood. So we don't know when you run the QFTs if patient has enough PBMCs to give you an accurate result. And isolation of PBMCs might improve functionality because of higher concentration of T cells. For the T-spot TB assay, we take the PBMCs from the whole blood, and they are standardized in each walls of the assay in the lab. At least you know that you have enough and same amount of cells in each walls when you run the test, so you get more accurate results. I want to thank you for your attention.